So we're going to spend the next hour talking about the real problem with diabetes. At least that's how I tend to think about it. You know, we spend a lot of effort, controlling glucose. We have all these drugs that we heard about, and we, flog our patients to lose weight and exercise and all. But the reality is it's the long-term complications of diabetes that really cause the biggest problem, not the day-to-day glucose management that patients have to do, but it's the risk of serious vascular disease that happens as a consequence of hyperglycemia. Obviously, the greater the hyperglycemia, the more poorly controlled the glucose level is, the greater the complication risk is. But it's the ultimate vascular disease that really is responsible for the biggest problems that patients have. Otherwise, diabetes would just kind of be an annoyance, right? But it's not. It's a real serious business. So we're going to spend a little time kind of describing the complications, talk a little bit about mechanism, which I think is very interesting and not completely understood exactly what are the molecular mechanisms behind the vascular damage that happens with hyperglycemia. And then we'll talk sort of specifically about some of the complications. We'll talk about retinopathy. We're going to talk just very briefly about renal disease, because I know you covered it in your renal course last year. And we'll spend some time talking about cardiovascular complications of diabetes. And then tomorrow, Dr. Arezzo is going to talk about neuropathy. So hopefully we'll have an interesting time. So when we talk about the complications of diabetes, and the chronic complications, I mean, you've heard the acute complications tend to be diabetic ketoacidosis, or that hyperosmolar non-ketotic coma, or iatrogenic hypoglycemia. Those are acute events that happen in diabetes. So these are what we call chronic complications, and we divide them into conditions of affecting the small vessels, microvascular or large vessel disease. So the classic microvascular complications in diabetes are retinopathy, nephropathy, and neuropathy, and the macrovascular complications are, very importantly, coronary artery disease, peripheral vascular disease, and cerebrovascular disease, and stroke. And we're just going to touch on all of these today. And I think this I think is sums up, I think, the magnitude of the problem, that diabetic retinopathy is still the leading cause of blindness in working age adults in the U.S. It's the leading cause of end-stage renal disease, so it's the leading cause of people heading into long-term hemodialysis or requiring a kidney transplantation. Diabetes is the #1 cause. It's the leading cause of non-traumatic lower extremity amputations because of the effects of neuropathy and sensory loss, predominantly in the lower extremities. And it increases 3- to 5-fold the risk of cardiovascular events and strokes. So when you put that all together, this is really a major burden of vascular disease that's associated with diabetes. The complications of retinopathy and nephropathy they're very characteristic and sort of pathognomonic features that are unique to diabetes. Neuropathy a little bit less. Cardiovascular disease and stroke, as you know, are things that affect even people without diabetes, but the risk of having these conditions is dramatically increased in the setting of diabetes. Now, before we start kind of going into what we understand about mechanism, I just wanted to back up a little bit and talk about hemoglobin A1c. I think we referred to this a number of times during our talk about diabetes in various ways. And this is a test that we use to assess glucose control, monitor a patient's ability to control their glucose. But it's formed by the non-enzymatic glycosylation of the hemoglobin molecule. So it's actually glycosylated hemoglobin, and it reflects the mean plasma glucose level over the preceding about 8 to 10 week period. So that's why it's so useful as a marker of sort of short-term metabolic control and used as therapy. The period of time that it reflects in terms of glucose is actually tied to the lifespan of the red cell, right? So there's a red cell turnover. Red cell lifespan is somewhere around 90 days. And so that has been useful in terms of understanding how hemoglobin A1c relates to mean glucose levels over a period of time. And there's been a lot of debate. We'll touch on it a little bit today about what the target should be. What is the right hemoglobin A1c to try to achieve? Obviously, we'd like to achieve a normal hemoglobin A1c if possible, because then we would have essentially eliminated the serious metabolic consequences of diabetes. But it's not, you know, there's a pro and con here, or risk-benefit, because the closer we get to normal hemoglobin A1c, the more commonly we have hypoglycemia, and there are other problems that could develop with really intensive management, which we'll talk about. So this target has changed over time. I think there's debate about it even now, but a widely accepted target for most people with diabetes is to try to have the hemoglobin A1c less than 7. There are times where the target is more stringent. 6.5 is, you know, is recommended by some agents, but I think 7 is, you know, generally agreed as a good level with individualization for specific patients. And more recently, as we've gained more experience with hemoglobin A1c and we've been able to test it in large populations of people with and without diabetes, we've been able to define what level of hemoglobin A1c can actually indicate whether someone has diabetes or not. And I put this here, that hemoglobin A1c 6.5 or greater can be used to diagnose diabetes. And that there's an intermediate range between 5.7 and 6.4 that's indicative of prediabetes, either impaired glucose tolerance or impaired fasting glucose, and that less than 5.7 is considered to be normal. And there's actually a website here that I give you where you can go and put in the hemoglobin A1c, and it will calculate the estimated average glucose that goes along with that A1c. And I think Dr. Shamoun probably mentioned this, he always does, in his talk on type 1, that this is a classic study that demonstrated that controlling blood sugar levels as reflected by hemoglobin A1c is the essential thing in terms of preventing the microvascular complications of diabetes. And so the DCCT was a multi-center study. We were a site here. Actually, Dr. Shamoun was the principal investigator here for this study, and enrolled patients with type 1 diabetes and randomized them either to conventional therapy, which at the time was 1 or 2 injections of insulin a day, and maybe once a couple times a week they'd test their blood sugar, to the kind of typical regimen now. This intensive therapy is what we typically use now, with multiple daily injections, frequent home glucose monitoring, carbohydrate counting, you know, very close attention to try to achieve normal blood sugar levels. And the results were just outstandingly, phenomenally impressive, right? With a reduction in retinopathy, over 50% reduction in retinopathy over the duration of the study, and a reduction in renal disease here shown by microalbuminuria, but more heavier protein, you know, greater amounts of protein also were reduced. So very, very dramatic, conclusive results, kind of once and for all. This was back in 1993, the major event in the kind of history of diabetes and its treatment. And it turns out that you're able to kind of calculate the relative risk for complications depending on what the average hemoglobin A1c was, in this case, over the duration of the study, and shows a very nice kind of curvilinear relationship where the higher the A1c is over time, the greater the risk of complications. When you start to get down into the level of, you know, hemoglobin A1c of 7 or lower, then you've dramatically reduced the risk of developing these complications. So let's talk about how this all occurs, right? When does the risk of complications begin? And this is sort of like maybe a little circular, but it's the definition of diabetes is actually based on when in the continuum of glucose levels, right? Because remember, plasma glucose is not, you know, there isn't really necessarily a threshold. There's a continuum, right? So when in plasma glucose levels do we actually start to see an increase in these diabetes-specific microvascular disease? And so so the microvascular disease like retinopathy and nephropathy, the risk really begins at the onset of hyperglycemia. And so for type 1 diabetes, we usually know when the onset of hyperglycemia is. Most patients who develop type 1 have a rather abrupt onset, often very dramatic. People can say, yes, I was 12, or yes, I was 20, or it was last year. It's pretty clear. They typically don't have a prolonged period of mild glucose elevations. They can, but typically they don't. And so it's pretty easy to tell when hyperglycemia begins. In type 2, on the other hand, the onset is slow. It often is undetected for many years. And so we don't really know, in most cases, when hyperglycemia begins in patients with type 2 diabetes. And so it turns out that some patients with type 2 diabetes present at the very first visit with already established microvascular complications, meaning that they had diabetes already for 5 or 10 years, and it was never detected. On the other hand, for macrovascular disease, there's evidence in type 2 anyway that the risk for the cardiovascular problems associated with diabetes actually begins even before the person has diabetes. So even in that pre-diabetic state of impaired glucose tolerance, for example, the risk of cardiovascular disease has already started to increase. And this notion that the clock starts ticking in terms of the risk of heart disease even before the onset of actual diabetes. And that's not the case in type 1. Now, this turns out to be, important in terms of when we begin to screen people for the complications of diabetes. So we'll get back to that in a couple of minutes. So what is it about hyperglycemia that leads to tissue damage, right? What are the mechanisms? How do we get from high glucose levels to the end organ diseases that we're going to talk about? And I think this is a really nice kind of scheme. This was developed by Michael Brownlee, who's on our faculty here, has been a major figure in understanding the molecular basis for diabetic complications. And so he says that it's the repeated acute changes in cellular metabolism related to insulin deficiency and hyperglycemia, and cumulative long-term changes in stable macromolecules, we'll talk about that too, that lead to tissue damage, and that other factors, including genetic determinants of individual susceptibility, play a role, and that other factors like hypertension or dyslipidemia that are not necessarily part of diabetes but can coexist with diabetes can accelerate the development of diabetic complications. And that, in general, the tissue susceptibility to hyperglycemic damage is related to the ability of the cells to downregulate glucose uptake in the setting of elevated plasma glucose levels, extracellular glucose levels. So cells that cannot downregulate glucose uptake in the setting of hyperglycemia are the ones that seem to be most prone to damage from hyperglycemia. I mean, you can imagine that, you know, high glucose, if it in the plasma or in the extracellular space, if it didn't get into the cell, then the cell would be less susceptible to damage. But cells that can't downregulate are the ones that are most susceptible, and these include, very importantly, endothelial cells. So there you have microvascular complications, and also neurons. So we're going to talk today about 3 pathways that have been received, I think, the most attention in terms of explaining how hyperglycemia leads to tissue damage. And we'll just talk about each one of them briefly. One is increased flux through the aldose reductase pathway. The other is increase in diacylglycerol and protein kinase C activation. And the other one is the formation of advanced glycation end products. And we'll go over each one of them in a little bit of detail. So the first one we'll talk about is the advanced glycation end products. And I mention this also because we just talked about hemoglobin A1c. So you know that glucose can interact with amino groups on proteins and lead to the formation of different compounds. There's an intermediate compound called a Schiff base, and then an Amadori product. And as the exposure of the protein to glucose is longer and longer, that there are more and more complex interactions that occur, leading ultimately to something called advanced glycosylation end products, which are a whole heterogeneous group of compounds that can develop through the interaction of glucose and amino groups. Now, hemoglobin A1c is actually what we call an intermediate glycosylation end product. It occurs over here. It's not itself thought to be toxic. It's not a sign of tissue damage, but it's in that pathway that we think ultimately on longer-lived proteins or in other situations can lead to advanced glycation end products and tissue damage. So this heterogeneous group of compounds called AGEs are very highly reactive molecules, and they induce the expression of reactive oxygen species. So they cause oxidative damage, and they're very reactive, interacting with a lot of other components within the cell and in the extracellular space as well. So AGEs can form intracellularly in cells that have intracellular hyperglycemia, these cells that can't downregulate glucose uptake in the setting of hyperglycemia, that these intracellular AGEs, through a variety of mechanisms, can alter the structure and the function of intracellular proteins and even cause damage to nucleic acid and DNA damage. AGEs also can form in the extracellular space. There's circulating AGEs can bind to specific cellular receptors. The most notable one is called RAGE, or receptor for AGE. Receptor for AGE, RAGE exists on macrophages, on endothelial cells, on a whole variety of cells in the body, and interaction of AGEs with this receptor leads to activation of inflammation, expression of cytokines, a lot of inflammation and further induction of reactive oxygen species happens as a result of AGEs interacting with specific cellular receptors. The other thing that can happen with AGEs in the extracellular domain is to actually change the character of long-lived proteins. The best example is collagen, where exposure of collagen to hyperglycemia actually leads to the formation of cross-links. These AGEs modify the collagen so that it becomes very stiff. There are cross-links formed, and it actually can impair the function of collagen. And this is an example of that you can see clinically. This phenomena here is called the prayer sign. So normally the tissues in the hand are very flexible. The tendons are flexible. If you try to put your hands together like this in the prayer sign, you can usually do it and put your fingers flat together. And in people with long-standing and poorly controlled diabetes, I think I've seen this mostly in type 1 diabetics, their tendons have become very stiff through AGE deposition in their collagen, and they actually can't put their hands together. So you could see this example here that the person can't make their hands flat because the tendons have been stiffened, as well as the skin has been stiffened by long-term hyperglycemia. So that's a kind of a clinical pearl. And people have looked at the AGE formation in skin collagen as a marker of diabetic complications that may be happening internally. This is a study from that DCCT, that large study that we talked about, that demonstrated the effectiveness of glycemic control in preventing complications. And if you just look at this part of the slide here, they actually took skin biopsies from the patients, and they looked at the amount of AGE formation in the collagen in the skin in relationship to complications, in this case retinopathy. And they showed you that the people with the lowest level of AGEs, in this case it's a compound called furacine, so low levels of furacine in the skin were related to low risk of retinopathy. And people with higher amounts of collagen AGEs that they found in the skin had much higher risk of retinopathy, pretty dramatically increased risk of retinopathy. Again, suggesting that what we can see in the skin, I mean, it's easier to do a biopsy of the skin, right, than the retina or some of the internal organs, that we can see that reflected in what's happening in the skin. And actually, some companies have developed a machine. This is called a Scout machine. There's one called the AGE reader that actually can non-invasively measure the amount of AGEs in the skin by taking advantage of their fluorescent properties. And this can be used as sort of a marker of whether someone's at risk for the microvascular complications of diabetes. The next pathway that we'll just touch on briefly is the aldose reductase pathway. So in the setting of high levels of intracellular glucose, the normal metabolic pathways are overwhelmed, and so you end up with increased flux through this pathway that uses the enzyme aldose reductase. And this leads to a number of kind of downstream effects within the cell that are thought to be toxic. The first thing is that it consumes the NADPH, and so it leads to depletion of reduced glutathione and oxidative damage. There's accumulation of sorbitol within the cell, which has osmotic effects that are damaging to the cell and also leads to depletion of an important signaling molecule called myoinositol. And it also, again, increases the NADH-NAD ratio, which itself seems to enhance the formation of advanced glycation end products and maybe the PKC activation that we also see in another pathway. So sort of multiple ways where increased flux through this alternate pathway for glucose metabolism seems to cause tissue damage. And the final pathway that's received attention is what's called the protein kinase C pathway. And again, this is a situation where there's increased flux of glucose in different alternate pathways within the cell, again, in cells that have hyperglycemia, intracellular hyperglycemia. And it leads to increased formation of this compound diacylglycerol, which activates protein kinase C, which ultimately has a lot of negative effects in terms of vascular function, increases membrane permeability, it alters basement membrane function, and leads to some blood flow changes that are detrimental. So we've identified these different pathways that may be mediators, important mediators for hyperglycemic tissue damage, right? And so you'd think, well, if these are the mechanisms for how hyperglycemia causes tissue damage, then why don't we develop a drug against these mechanisms, right? I mean, we try our best to control glucose levels, but that's not possible to do perfectly. So what about these mechanisms as targets for therapy? So people have developed drugs that either prevent the formation of AGEs or break the AGEs that are already formed, and the clinical trials have been essentially negative. There's been no benefit. It works great in rats and mice, but in the human clinical trials there was no evidence of a beneficial effect on vascular complications. Similarly, there have been a number of aldose reductase inhibitors that have been developed to prevent the metabolism of glucose through the polyol pathway, to prevent those negative downstream effects from happening. And although there's still some aldose reductase inhibitors in clinical trials, in general, this has been a disappointing approach as well. It's been studied, I think, for the last 15 or 20 years, and we don't have any effective therapy that's emerged from this at this point. And similarly, for the protein kinase C pathway, inhibitors, specific inhibitors of protein kinase C, which are designed to prevent the downstream effects of PKC activation, have also been negative. So we don't have, at this point, a specific therapy that's based on these molecular mechanisms, right? And that's led to a hypothesis or a view that, you know, maybe these pathways that we're observing, and including another one, the hexosamine pathway, which we won't discuss, that maybe these are downstream of a more important mechanism. And again, I'm quoting Michael Brownlee here, who has really been a leader in the field, and his research is indicated that it actually may be mitochondrial superoxide overproduction that's the kind of key mechanism for all of these various pathways for diabetic complications, so that if you attack one pathway, you're still going to have tissue damage from the other mechanisms as well, and that maybe what we need to do is have a mechanism for dealing with or preventing the overproduction of superoxide as the kind of global way to approach prevention of diabetic complications. We don't have it yet. I think there's a lot of interest in trying to leverage this insight to develop specific treatments that will prevent the diabetic complications, but we don't really have it yet. Yeah.
If that were true, couldn't you just treat each of the three individual complications together?
Yeah. That's a thought. I think if you asked Dr. Brownlee, he would probably tell you that they're doomed to failure, partly because the superoxide production by the mitochondria may be mediating other pathways that we don't even know, right? That's sort of the fundamental event here that's leading to tissue damage. The other thing I'll say about the various drugs that have been developed to deal with the individual pathways, we don't really know whether we don't know for sure whether they weren't effective because of the alternate pathways, or they're just not very good, or maybe the hypothesis is wrong, right? That these pathways are really what's responsible for the complications. So it's an area that's in flux. Now, I'm going to get back for a minute to talk about the DCCT study that we keep going back to, because of another insight that it gave us about the mechanisms of diabetic complications. And this has to do with what happened after the DCCT was completed. So, during the study, the two groups, the conventional treatment and the intensive treatment groups, had very different hemoglobin A1Cs. The intensive group had a hemoglobin A1C around 7. The conventional group had a hemoglobin A1C in around 9 or so, and they maintained this throughout the DCCT study. But when the study was over, all of the participants in the study were essentially returned back to their own physicians for management. They all were given, even the ones in the conventional group were given information about how to intensively manage their diabetes. And you could see, and then we continued to follow these people over time, not treating them, but just having them come in once a year and monitoring their progress. And you could see that after the first year, the hemoglobin A1Cs in the two groups were pretty much identical. The people who were in the intensive group kind of loosened up a little bit without all of the encouragement from the study staff, and their hemoglobin A1Cs came up a little bit. And the people in the conventional group heard about the treatment, were informed and given some support, and went back to their doctors, and as a whole, their blood sugar control improved. And for many years, the hemoglobin A1C levels in these two groups have been the same. In fact, we're still following these same participants more than 20 years after the original study. So lots more is hopefully going to be learned from the same group of people. But what's really interesting is that we continue to monitor the people for retinopathy and renal disease as well. But here I'm giving you the example of retinopathy. And you could see that in the conventional treatment group, now this is following DCCT. This is into the period of time where the blood sugar levels were essentially identical in the two groups. That still, the conventional group had much higher rates of retinopathy than the intensive treatment group. Here, 7 or 8 years out, when actually their blood glucose levels were no different, and that if you actually just look at the slope of the increase here for the conventional group is very steep, and there was very minimal increase over this period of time in the people in the intensive treatment group. And this led to the concept of metabolic memory, right? That the persistence of abnormal cellular function and the progression of these microvascular complications despite the later achievement of normal or improved glycemic control. So that the people in the conventional treatment group had initiation of processes that led to the development of complications that was not stopped by the improvement in their glucose control. And on the other hand, people who had initially really good glucose control were still relatively protected from microvascular complications despite having higher glucose levels over many years. And I think we don't really understand completely why this occurs, but there are a number of theories. I think a leading one is that there may be some epigenetic modifications that occur as a consequence of hyperglycemia that kind of live on in generations of cells that continue to cause problems many years after even the control of glucose or the normalization or near normalization of glucose levels. Others have proposed that it may be this advanced glycation end products that develop within cells. These AGEs are very durable. They don't tend to break down. They cause problems. They're irreversibly formed. So so that once they're there, they don't ever really go away, and maybe that could be responsible for this very long-term effect of hyperglycemia. And then again, mitochondrial ROS generation has been implicated as well. I think I'm telling this to you not because we really understand exactly why this phenomenon occurs, but it's led us to the understanding that early metabolic control is probably very important in terms of preventing the long-term complications of diabetes, and that intervening once someone has established complications in general is not very effective. So prevention from a very early stage is really the important thing in reducing the rates of complications. Another phenomena that's received attention recently, again, where I'm telling you about things that are still somewhat controversial, but it's this notion that in addition to sort of mean glucose levels over time, that the variability in glucose levels may have an independent effect to promote tissue damage and diabetic complications. And so that even the transient exposure to hyperglycemia can cause persistent increases in pro-atherogenic and pro-inflammatory gene expression. You can demonstrate this in cell cultures very nicely, but whether this is really operative in humans or not isn't clear. I'll just show you an example of one experiment here. This is actually a picture of an insulin pump, a person wearing an insulin pump. But over here is a glucose sensor. And so these are increasingly being used, again, mostly in type 1 diabetes. And it's a continuous sensor of interstitial glucose levels. And so they're showing you a sort of hypothetical picture here of two hypothetical patients, Bill and Dan. And these two people have supposedly the same hemoglobin A1C. So their average glucose is the same. But you can see Dan here in the red has big swings in his glucose. He goes from hypoglycemia to hyperglycemia, back and forth, up and down all the time. Whereas Bill maintains his glucose levels in more or less a much narrower range. So even though they have the same average, this person who has these big swings, you can identify them, I guess, now with using this kind of a sensor. And so they've done an experiment where they had patients with these two types of glucose patterns, and they showed that the people that what's called the mean amplitude of glycemic excursion, so a measure of the variability of the glucose levels is associated with this marker of oxidative stress, suggesting that glucose variability itself may be an additional factor that promotes inflammation and oxidative stress that eventually could lead to diabetic complications. So the take-home messages here are glycemic control can prevent microvascular complications. However, once established, control is not effective. Therapies directed against specific molecular targets have been disappointing, and that currently surveillance, glycemic control, and adjunctive therapies like ACE inhibitors, we'll talk about in a minute, are really the keys to good outcomes for people with diabetes. So we're going to spend the next few minutes going over some specific complications and how they present clinically and how they're treated. Diabetes can affect vision in a number of ways. So the classic thing, of course, that we think about in terms of diabetes is diabetic retinopathy, but it's worth mentioning that diabetics also have accelerated cataract formation and a greater frequency of glaucoma. These are not diabetes specific, but they're more likely to occur. And also that hyperglycemia can cause temporary changes in the lens, the eye, causing refractive error. So it's not uncommon for someone to develop diabetes to present actually initially to their eye doctor. They go and they say, my vision is blurry all the time, I must need new glasses. And an astute ophthalmologist can pick up the fact that actually what they have is swelling of their lens from the hyperglycemia, and that this is a temporary change that will improve with control of glucose levels. But the things we're going to talk about today is really diabetic retinopathy and the various features: macular edema, vitreous hemorrhage, macular ischemia, and retinal detachment. These are the things that lead to permanent vision loss in people with diabetes. So, as I mentioned before, diabetes is the #1 cause for blindness in the United States in sort of middle or working age people. Retinopathy is the most prevalent of the microvascular complications. It's present in about half of people with long-standing diabetes, although most people will not suffer vision loss from this. But if you look carefully with a dilated fundus exam, you can see evidence of retinopathy in a large percentage of people who have diabetes. And that the retinopathy tends to be more severe in type 1 diabetes, maybe largely because they're exposed for a longer period of time. If you remember that people tend to begin their type 1 diabetes in childhood or early adulthood, they just have more years of exposure to hyperglycemia and more chance to develop complications like retinopathy. So what are the processes involved in the pathogenesis? So number one is there's vascular dysfunction, and part of it is increase in this growth factor, vascular endothelial growth factor, that changes permeability of the vasculature in the eye. There's loss of supportive cells called pericytes, and ultimately there's neovascularization or growth of new vessels in response to the ischemia of the retina, and these new vessels are prone to hemorrhage and can cause retinal detachment. But there's also effects of hyperglycemia on the neurons within the retina that can lead to loss of synaptic activity, apoptosis of the neurons, sort of a neuropathy of the neuronal cells within the retina. And finally, there's inflammation. The microglial cells in the retina become activated because of the different pathways that we talked about. There's more inflammatory cells and adhesion of inflammatory cells to the vessel endothelium, and ultimately leading to inflammation in the eye. And this is just a nice picture from a recent review in the New England Journal showing you some of the effects in diabetic retinopathy, where there's leakage of red blood cells out of these capillaries that have increased permeability. There's apoptosis of these supporting pericytes, and there's reduced amounts of this platelet-derived growth factor, which is important for normal vascular health. So in general, clinically, diabetic retinopathy is kind of classified into two categories. There's non-proliferative or background retinopathy, which is generally a mild stage of the disease, and then more severe or proliferative retinopathy. In the early stages, there's basement membrane thickening, loss of pericytes, there's leakage from the retinal capillaries, and you can have macular edema, which itself can lead to at least temporary vision loss. In the more advanced stages, there's actually loss of capillaries, there's retinal ischemia, which leads to the induction of various growth factors that like VEGF, which eventually lead to neovascularization, hemorrhage, and vision loss. And so these are some of the things that you can see when you look in the eye. You can see, very hard to see here, but microaneurysms, which are little tiny sort of red dots that you can see on the retina. Areas of hemorrhage, and exudates, which is actually leakage of plasma proteins onto the retina through these hyperpermeable vascular cells. In proliferative retinopathy, there's growth of new vessels, abnormally tortuous, and vessels that are prone to rupture. And that ultimately the rupture and the scar tissue that forms as a result, the inflammation and scar tissue that forms as a result of the rupture, then leads to traction retinal detachment. So scar tissue tends to shrink, it pulls the retina away from its supporting surfaces and leads to permanent vision loss. So diabetic retinopathy is diagnosed by a dilated fundoscopic exam. This is something that you can do, although typically we rely on ophthalmologists to do this exam, using dilation and good equipment. But it is something that can be done clinically, and if you practice at it, you can actually pick up some changes. Fluorescein angiography is something that's done to detect increased vascular permeability. It's a fluorescent substance that's infused intravenously, and then you look in the eyes, and if there's leaky capillaries, you could see this substance appearing on the retina. And something called OCT, which is a technique for measuring macular edema. One point about screening for retinopathy that's really important to make is, remember, we said when does the risk of complications start? And so in type 1 diabetes, the risk begins, at the point of diagnosis, but diabetic complications generally, the microvascular ones, require exposure to hyperglycemia for 5 or 10 years before there's clinical evidence of any of the complications. And since we know the date of onset for diabetes for most patients with type 1, it's usually recommended that they have their first screening eye exams about 5 years after diagnosis. Whereas in type 2s, because we don't really know when their diabetes developed, we start screening them as soon as we are aware that they have diabetes. And during pregnancy, there can be an acceleration of retinopathy due to hormonal changes, and so it's recommended to monitor women very carefully for retinopathy during pregnancy. So this is that fluorescein angiography I was telling you about. You could see that there's escape of the tracer into the areas of the retina that look normal to the naked eye, but when you test it in this way, you can see that there's increased vascular permeability. And this is ocular coherence tomography, which actually sort of like gives you a cross section of the retina and can show you here evidence of macular edema, which may not be visible to the naked eye. So how is diabetic retinopathy treated? Well, in addition to our usual measures of blood sugar control, specific treatment for retinopathy includes laser photocoagulation. So there's actually these abnormal vessels that grow in response to ischemia in the retina. Those are the ones that are prone to bleeding and hemorrhage. And so the laser treatment actually destroys those abnormal vessels so that they won't leak. There's also increasing use of intravitreal injections, so injections into the vitreous of the eye of molecules against a growth factor, so an anti-VEGF monoclonal antibody, or also glucocorticoids for their effect to suppress inflammation. And occasionally, surgery is needed to remove debris and resolving blood clot from the vitreous, which can restore vision. There's some evidence that treatment with ACE inhibitors and angiotensin receptor blockers may also help to prevent the progression of retinopathy. And interestingly, for reasons that are not at all clear, fenofibrate, which is a drug used to treat hypertriglyceridemia, has been shown to have some benefit in the progression of retinopathy. And these are just some pictures of focal and panretinal laser treatment. We'll kind of skip over them. Here's a picture, kind of chilling, of intravitreal injection of glucocorticoids or antibodies against VEGF, and then vitrectomy. Okay. So the key points about diabetic retinopathy, and this is a very important point, is that vision is usually normal until retinopathy is very advanced. And so this is an important reason why you have to send patients for routine screening independently of whether they're having vision symptoms or not. It's really early diagnosis at a really early stage of retinopathy where treatment with laser photocoagulation can be very effective. So treatment can stabilize but cannot restore vision. If vision is lost as a result of retinopathy, you can't get it back. And so early treatment is critical. And then finally, controlling glucose and blood pressure helps to prevent retinopathy. But like with so many things in diabetes, once it's established and once it's on its way, glucose control is not going to reverse it. Okay. So we're just going to very quickly talk about nephropathy because I know you've seen this before, right? The characteristic lesion of diabetic nephropathy is this nodular glomerulosclerosis or the Kimmel-Steele-Wilson lesion. Overproduction of extracellular matrix in the kidney. Now, the development of diabetic nephropathy, kind of the natural history of diabetic nephropathy, is something that, amazingly, we're still understanding. But the kind of classic view is that early on in diabetes, there is actually hyperfiltration. Right? There's an increase in the GFR, probably as a consequence of hyperglycemia itself. And that kind of normalizes with treatment of diabetes, and it tends to be fairly stable for a number of years. But in people who are destined to develop renal disease, there's a slow, gradual decline in GFR over many year period, 10, 20, 30 years. On the other hand, urine albumin excretion has been proposed as an early marker of the development of kidney disease, and that microalbuminuria, meaning small amounts of albumin in the urine, can be detected using sensitive assays many years before you start to see a decline in GFR. And it's at the time when the protein excretion actually increases, here's the grams per day of protein, it gets really high, is the time when GFR starts to decline. And so the microalbuminuria has been proposed as the earliest clinical marker of diabetic kidney disease. But it turns out that it's not that simple, like a lot of things, and that many people who develop microalbuminuria actually never develop serious kidney disease. They may revert to normal albuminuria. They maintain a normal GFR. But it seems as though the people who progress, who have increasing amounts of proteinuria up to what they call macroalbuminuria, are the ones who are most likely to develop eventual decline in GFR and end-stage renal disease. And it's also true that there are some patients who never go through a stage of albuminuria, but just go directly from what seems to be normal renal function, maybe a period of hyperfiltration, but they develop a reduction in their GFR without ever having proteinuria, which has really been considered, in most cases, the hallmark of diabetic kidney disease. So the usual pattern is for small amounts of albumin, progressively increased protein excretion that goes along with reduced GFR, but there are some people who seem to develop renal disease without albuminuria. That just kind of highlights that here. So the treatment goals in diabetic kidney disease, obviously, controlling blood sugar and blood pressure are very important. Specifically, drugs like ACE inhibitors and angiotensin receptor blockers have been very effective at preventing the worsening of proteinuria and decline in GFR. Controlling blood pressure by any mechanism is beneficial, but in particular, the ACE inhibitors and ARBs seem to have an additional renal protective effect. Okay. Now we're going to spend the last few minutes talking about macrovascular disease. And I think it's good to finish up with it because I think even though retinopathy and kidney disease are very important complications in diabetes, that it's actually heart disease that's the biggest killer for people with diabetes, especially when we're talking about type 2 diabetes. So that the risk of myocardial infarction is up to 5-fold increased compared to sort of age-matched people who don't have diabetes, and it's the leading cause of death in type 2 diabetes. So obviously it's a very important problem. As we mentioned, stroke and peripheral vascular disease are also increased. These conditions are not specific to diabetes, but are accelerated in diabetes, occur at younger age, are more aggressive, have more morbidity associated with them. And we're going to focus on that, on atherosclerotic cardiovascular disease and myocardial infarction. But I do want to mention that there is an entity that's been referred to as diabetic cardiomyopathy, which is not on the basis of atherosclerosis, but is thought to maybe be a microvascular complication, small vessel disease within the heart, or maybe not vascular at all, but some kind of metabolic disturbance in cardiac myocytes that happens as a consequence of diabetes. So we do know that people with diabetes are at increased risk for congestive heart failure, and whether there is a specific entity called diabetic cardiomyopathy or not, I think is a little controversial, but the fact that that they have more congestive heart failure is definitely true. So how is it that diabetes affects vascular function? And here we're talking about large vessels, right? About, say, for example, coronary arteries. And so there's lots of evidence for negative effects of hyperglycemia on a number of important parameters. The first one is that hyperglycemia can alter endothelial function. So there's an impairment of nitric oxide activity, the hyperglycemia, the oxidative stress that's associated with hyperglycemia can quench or inactivate nitric oxide. There's also increased expression of vascular adhesion molecules like VCAM1 that promote the adhesion of circulating monocytes to the vessel wall that leads to the foam cell formation. And in general, there's accelerated atherosclerosis. There's some evidence also that the atherosclerotic plaques that form in the setting of diabetes may be more vulnerable to rupture, may be more prone to rupture, and that's what triggers acute coronary events like a myocardial infarction. And there's quite a bit of evidence that diabetes is associated with a prothrombotic state, that hyperglycemia can activate platelets, make them more sticky, make them more likely to clump together. There's impaired fibrinolysis due to increased levels of plasminogen activator inhibitor 1 that happens both as a consequence of diabetes, hyperglycemia, but also in insulin-resistant states. And so the bottom line is that there's more of a tendency towards thrombosis, and it's this thrombosis and clot formation that's responsible for acute vessel occlusions and acute coronary events, for example, or ischemic strokes. So what do we know about prevention of cardiovascular disease in diabetes? And again, we're going back to the Diabetes Control and Complications trial, which has been so informative in terms of understanding complications in type 1 diabetes. Early on in the DCCT study, there were very few cardiovascular events. This was basically a young population. But as I told you before, this cohort of patients has been followed over the years. This is out to about 20 years of follow-up here. And then there were enough cardiovascular events in the two treatment groups, they were able to compare them. And you can see here that the conventional treated group, which received their treatment way back here in the beginning of the study, had higher rates of, this is any cardiovascular outcome here, and this is MI, stroke, or death from cardiovascular disease here. And that overall, there was a dramatic reduction in cardiovascular outcomes in the intensive treatment group in DCCT. Again, remembering that these two groups had similar glucose control for the last 15 years. So there was something very profound that happened from early control of glucose that led to a dramatic reduction in cardiovascular outcomes many years later. So very impressive. So intensive diabetes therapy has long-term beneficial effects on the risk of cardiovascular disease in patients with type 1 diabetes, right? So what about type 2? Well, that's been a much more complicated story. And this is another study that was done slightly after the DCCT, and this is called the UK Prospective Diabetes Study. It's a study in type 2 diabetes looking at different strategies for glucose control and the development of complications, including, in this case, myocardial infarction. There was a conventional treatment group and a more intensive group. We don't have time to go into the details of the study design, but there was a difference in glycemic control between these two groups. And in the end, there was a modest risk reduction, but not very impressive, about 18%. And they didn't even see this until they had followed this population for many, many years. So maybe an effect, but not very strong. And more recently, there have been 3 major randomized clinical trials designed to test the hypothesis that intensive glucose control will prevent heart disease, cardiovascular disease in type 2 diabetes, and they were all negative. So there's the ACCORD study, the ADVANCE study, and the VA diabetes trial, all major studies with the hypothesis that controlling glucose would prevent heart disease, and they all were negative. And this was a big surprise to everybody in the community who figured that, well, what's good for type 1 has got to be the same for type 2, but that really doesn't seem to be the case. So what's the difference, right? So I don't think we know the answer for sure, but these are some of the hypotheses about why we see such a different effect in the two types of diabetes. Type 2 diabetes is a much more complex metabolic disorder. Remember I said last week it's hard to understand, harder to understand than type 1, and that's because there are multiple metabolic defects. There's, in addition to hyperglycemia, there's a characteristic dyslipidemia, there's more hypertension, most people are obese, there's this whole constellation of cardiovascular risk factors that are called the metabolic syndrome, that this complex metabolic disorder is very characteristic of type 2 and not type 1. It's also possible that the interventions in these more recent studies in type 2 diabetes may have been started too late in the course of diabetes. Remember, the DCCT people were young. In that type 1 study, they were teenagers or young adults when they started in the trial. And it may be that treating a middle-aged population that maybe has had diabetes for 5 or 10 years or even longer, maybe it's too late to affect the course of macrovascular disease. There's some people who say that if you have atherosclerosis and you aggressively lower the glucose levels, maybe you will destabilize the atherosclerotic plaques and make them more prone to rupture. Or maybe the aggressive glucose lowering led to more hypoglycemia, and the hypoglycemia stimulated the autonomic nervous system, and this led to arrhythmias and sudden death, and no benefit from from glucose control in terms of prevention of cardiovascular disease. And a final theory is that maybe it's the drugs that we're using to treat type 2 diabetes. Remember, type 1s, they only were treated with insulin. In type 2s, we use sulfonylureas. Maybe, they have negative cardiovascular effects. A lot of thiazolidinediones were used that may have some negative cardiovascular effects. We don't really know. But there are a whole cocktail of drugs that are used in some of these studies, and maybe they themselves have some negative effect on cardiovascular status. Okay. So the bottom line we take away from these recent experiences is that if we want to prevent heart disease in people with type 2 diabetes, that we have to embark on very aggressive control of all the standard cardiovascular risk factors. These include lipids and blood pressure. We treat the hypercoagulability using aspirin. We encourage weight loss and smoking cessation. The optimal glycemic target for prevention of heart disease is not at all clear, but we know that if we want to prevent the microvascular complications, that we do want to try to achieve hemoglobin A1Cs, in a reasonable range, and that's where the less than 7%, I think, really comes from. And that we should probably begin risk factor modification very early in the course of diabetes if we really want to have an impact on the eventual development of heart disease. And I'll just I'll show you a study that was successful. This was a study where they used multiple risk factor intervention in a population of type 2 diabetes, where they treated aggressively not just glucose, but lipids and blood pressure and aspirin therapy over an 8-year period. And compared to a control group, they had dramatic reduction in cardiovascular mortality and cardiovascular events. So a comprehensive approach that deals with all of the cardiovascular risk factors is really what we need to have. And just the final slide I'm going to show you has to do with the clinical course of type 1 diabetes. I think as a result of the DCCT and all that was learned about intensive management for type 1 patients, that the outlook now for patients with type 1 diabetes is so much better than it was in the pre-DCCT era. That proliferative retinopathy with vision loss was very common. It's much less common now. Kidney disease, clinical nephropathy was much more common. It's in the current era really reduced, as well as cardiovascular disease. And that less than 1% of the DCCT cohort became blind, needed renal replacement, or had amputation after 30 years of type 1 diabetes. And that it's not just glucose. There's more aggressive control of all of the cardiovascular risk factors. But I think especially in the case of type 1 diabetes, you can really see that despite having a sort of a magic bullet that can restore euglycemia or attack the metabolic basis for the complications, we can really go a long way and have gone a long way in terms of reducing the complications and improving the outlook. Okay, that's it. Thank you. So tomorrow we'll finish up with neuropathy and our patients.